We would like to welcome all our participants today for our online session with Dr. Ali Habib and evidence-based versus clinical-based orthodontics. Welcome, Dr. Ali. It's a great pleasure having you with us today. As usual, we can start the session now.
Okay, thank you very much, Lamis. Good afternoon, ladies and gentlemen. I would like to start by thanking Ormco for having me here today with you. I would like also to thank you for coming today. And if you feel that sound is not clear, please let me know so I can do any changes. The title as written is Evidence-Based versus Clinical-Based Orthodontics. There is an interesting thing that I always think about, which is that we as orthodontists, we still practice straight wire appliance, which is a 50 years old appliance, and we like it. And if you ask orthodontists in general which appliance they practice in their clinic, most of us answer either 5 or 6, because I tried this in the previous lecture, and most of them answered either 5 or 6, mainly straight wire, with some cases of self-ligating brackets and maybe other appliances, or straight wire appliance with some cases of clear alliance and maybe appliances and maybe others. A few were dedicated to clear aligners, and few were doing self-ligating only, but most of the time we do mainly straight wire and adding other appliances to our practice. And why is that? Because straight wire appliance still is the bread and butter of orthodontists. We like it. It's we were born with the fixed appliance, so we know exactly what it is, and we are very good at it. And unfortunately, most of the new orthodontic appliances are not evidence-based, and this is what we were told by our authorities, that it's not evidence-based, so we shouldn't use it. And some might say that we were taught straight wire appliance in our undergraduate, in postgraduate, and we are not willing to change. Some might say that we don't think it's the new appliances are effective. And this is very common, that every time we see a new appliance is not effective, and we need to have an evidence for it, and then we think about it. This is how we approach things. In addition, the fixed appliance is very inexpensive, and it's affordable. We can do our practice without paying a lot of lab fee. And some might say we don't know how to use the new ones, and this is fact. When you have new appliances, you assume that you know them, and you add them to your practice after attending a lecture or two, or a hands-on workshop, and then you think that you know. And in reality, we don't know about it, and I'll tell you why. That's why we still practice fixed appliance. And as we know, anything we should practice nowadays should be evidence-based in order to raise the quality of work you do and the outcome of treatment. Let's ask this question: is the straight wire appliance evidence-based? Based on what I know, when fixed appliance was started to be used, there were a few studies, but none of them were randomized clinical trials. There are some new randomized clinical trials that they use fixed appliance as control group. So we assume that it's evidence-based, and we use it. And I mean, everybody is using it, and we believe in it 100%. Is it effective appliance? Does it give us a predictable outcome? The outcome is predictable and we can measure it. Does it give stable long-term results? Does it cause no harm to patients? All these questions, if you try to answer them, the answer will be, to some extent, no. We don't predict our outcome. Sometimes when we want to align a level, we just run night-eye wire and we close our eyes until next visit, and next visit we see the teeth are level, but we're not sure which tooth moved in which direction. We have problem with retention. with stability. That's why we tell our patient that, like, not all of us, but many advise patient to have long-term or long-term retention all the time. And sometimes we cause harm to the patients because, of course, we know that we cause white spot lesions. Sometimes we cause root resorption and other deleterious effects. So it's not really that fancy appliance, but we still love it, and it does the job, and it helps to fix all our problems, and we can treat any case with fixed appliance. So although straight wire appliance is the most common one, it does have many limitations and risks. First of all, as you know, it's ready-made appliance, one fits all. Imagine that we use prescription of Andrews or Roth or MBT that were done on certain population. We use them on all patients all over the world. As I said, that the outcome is not predictable to some extent or to a great extent, because with straight wire, we don't know the exact action that is taking place on specific teeth. Anchorage, this is a big problem that we lose anchorage when we use fixed appliance. That's why with the introduction of mini screws nowadays, we solve this problem to a great extent. Friction is also another chronic problem that if you use just conventional fixed appliance, you're going to face it, and it's one of the reasons for lengthening treatment time and losing anchorage is friction. The response to treatment is unpredictable to some extent. Why? Because, you know, it's a different biology, or let's put it this way, we don't understand biology of tooth movement that really good, because sometimes teeth move very fast, sometimes they don't move, sometimes they get ankylosed. So we have a lot of unpredictability in the response of tissues to our tooth movement, and sometimes roots resorb. Lengthy treatment, it is very lengthy treatment, 2 years, 3 years with fixed appliance. It's a hell of experience to the patients, and fortunately, we're really very good in convincing our patients to wear fixed appliance for 2 years plus or minus. And it is not acceptable by some patients. That's why nowadays most of not most, like a lot of adult patients seek clear aligner, seek alternatives. They try to do lingual, they try to do a clear aligner. So it does have limitations, functional appliance, the fixed appliance, sorry. Did I say functional? It is the fixed appliance. So when we talk about the unpredictability, as you know, if you go to biomechanics, you can tell that fixed appliance consists of multiple couples. So having multiple couples in an appliance will make it very difficult for you to predict the outcome of treatment, especially with these teeth that have different root shape and configuration. That's why if you're not really good in handling fixed appliance, like sometimes some general dentists try to do extraction cases, and this is what they end up with. They might lose anchorage anteriorly and posteriorly, and they might cause tipping, they might cause deep bite and cause a lot of problems that needs very proper treatment to fix it back to normal. And this is after treatment. And also this another problem, another patient, sorry, that was treated again with by somebody who is not expert in biomechanics, and look at the deleterious effect that the patient ended up with. This is from the inexperts. From the experts, sometimes we cause white spot lesions. The other day, we did the study in Saudi Arabia, in Jeddah, and we were comparing the white spot lesion prevalence in extraction cases versus non-extraction. And guess what? At the end, we found that almost all the patients, whether extraction or non-extraction, had white spot lesions, which indicates how dangerous what we do. So it is a problem that is caused by the lengthy treatment using fixed appliance. And unfortunately, with fixed appliance, sometimes we do a lot of mistakes, and we move teeth in undesirable direction, and then because we are really good, we can fix it. For example, sometimes we lose anchorage, and there are many factors behind losing anchorage. Might be you, might be the patients, might be the teeth. So we lose anchorage somehow, and then we are really good fixing it by elastic. We can fix that, but we cause a problem. We cause harm to the patient. Sometimes we extrude posterior teeth to correct teeth bite, and we know that extrusion of posterior teeth might cause or might be unstable. That's why we ask patients for lifetime retention. Sometimes when we want to align and level, resolve crowding, we flare teeth and then try to retract them. We use intraoral distalization or try intraoral distalization using different appliances, intraoral appliances, and we end up with flaring incisor instead of distalizing teeth, and we call it successful treatment. And we claim that this is non-compliance intraoral distalizers, which are really, in reality, they are not distalizing, they are flaring incisors. Sometimes we cause white spot lesions, as I said, and caries, and then refer patient to restorative work, and we fix it, but we cause harm to the patient. So we still consider the fixed appliance a state-of-art appliance, and we still teach it in schools. And our new graduates, they are really good in mastering this appliance, and we're still struggling to convince authorities to add new appliances to the curriculum. And in many schools, they don't. They still want to have the fixed appliance as standard of care. And even if you want to add, for example, clear aligner or self-ligating brackets, you might allow the student to do 1 or 2 cases maximum, not more, because you want, this is our rule, is to teach him fixed orthodontic appliance, the traditional fixed appliance. Yeah, sometimes people, they try to use MBT versus Roth versus other prescription, but still at the end, all of them are fixed orthodontic appliance. I'm not saying that the fixed appliance is not good. It's very good if you are expert in it, but as I said, it has many limitations. And we can, with the limitation, we can still fix teeth. We can do wonderful things like this case with a lingually positioned incisor and crossbite and anterior crossbite. We can nicely move the teeth, and we end up with good results. So it's still good appliance. But the question is, do we really want to continue using it? It's to me, I want to change. I think it's the time. And in my opinion, like in 10 years from now, I don't think anyone is still be practicing fixed or straight wire appliance. So maybe we should think of alternatives. And this is what I am calling for through this presentation, that we have to consider new appliances. Unfortunately, when we have new appliance or technique introduced to our community by, of course, companies most of the time, it's always like a nature of our authorities to resist the change. And they say this is not evidence-based. And we keep talking to our graduates and residents and students and even the practicing orthodontists that this is not evidence-based, and we tell this in all conferences and symposium all around the world. And when you say not evidence-based, what we understand from that, and this is not good appliance, so we don't have to change to it. It's not evidence-based because it's new appliance. So unfortunately, at the end, because of this resistance, we continue practicing straight wire appliance, and this is the main problem, in my opinion. So graduates and residents all get confused by this. The authorities, the academicians, they seek or they tell them that you have to use evidence-based appliances, and companies, they come, and we invite companies to come to our school and tell them, okay, show us what you have, and they promote for new appliances and new mechanics. And we, they bring sometimes commercial doctors to promote for their work or their appliances in non-scientific way. When you want to present something, you have to show evidence that it does work, and the evidence has to be scientific, regardless whether there is research supporting it or not. and sometimes they do a good job in promoting their appliances. So the people get stuck between these different opinions. And when they go out, the new residents and graduate, they go out, practice outside in private clinics. They find that, oh, there are other orthodontists who depend on their experience in doing braces. And some of them, the good ones, they do only one or two choices and they believe in them and they're expert in them and they do them, although they're not evidence-based. So this is the confusion that we are in nowadays, and I hope that I can give you guidelines today to solve this problem. Let's first start by defining evidence-based practice. In 1992, evidence-based practice was introduced. This concept was introduced to medicine, and it's basically, it means that we have to have scientific evidence, mainly research, to support what we do. And what the idea behind it was to improve the quality of healthcare, reliability, and ultimately patients' outcome through the provision of healthcare that is influenced by the best available research evidence and devoid of rituals and tradition. So like nowadays, people not rushing to use vaccines because they still want to see the results of clinical trials, which were done on a large population of patients. Although evidence-based practice is the gold standard for effective healthcare practices, still there are some people that are in conflict with this concept. They encountered, when they applied this evidence-based practice, they encountered multiple difficulties in different specialties other than medicine. Of course, you know, the evidence-based practice is applied on different specialties also, education, law, and dentistry nowadays. We strongly advertise for it and promote for the evidence-based practice. Unfortunately, in my opinion, we're facing difficulties in applying evidence-based practice in orthodontics. Why? Because, very simple answer, because we do very lengthy treatment. Imagine that we do 2 to 3 years of treatment, and it's the patient's flow is very low. We don't end up with adequate number of patients when we do randomized clinical trials. So when we say evidence-based, most of the time we want to draw our evidence from randomized clinical trials. Do we have good clinical trials, randomized clinical trials? We do, but few of them. And most of the time, if you read the conclusion, you find that the authors conclude that one of the problems of this study is the sample size. So they recommend running or conducting future study, randomized clinical trial with adequate sample size. So most of the time, running or doing randomized clinical treatment, randomized clinical trials on orthodontics is questionable because of the lengthy treatment that we do. The outcome of growth also is highly variable. We have different craniofacial growth and development, which varies from one person to another. For example, if you look at the studies of class 2 treatment, and because of the sample size, their inclusion criteria were broad criteria. That's why it's just included any class 2, growing class 2 with increased overage. Although among these, we have some of them that have favorable growth and some that don't. According to Bjork, he classified patients into forward growers and backward growers, and definitely the results will be different. Also, we deal with highly variable periodontal and bone response to tooth movement. So those studies that are done to evaluate the rate of tooth movement, sometimes we see variability because of this. Because sometimes in your clinic, you can move teeth very fast and sometimes you don't, and we don't know why. Also, the way we practice, we have multiple or many appliances all over the world, and unfortunately, we don't stick to one appliance. Especially the juniors and new graduates, they go jump from one appliance to another because of the continuing education that we do. And I like this appliance, and the speaker was really very good in introducing his appliance, then I say, why not I try it? Okay, then we keep trying without knowing exactly what appliance I really want to use in my clinic and stick to it. You don't have to change every time and then. And as I said, finally, the randomized clinical trials in orthodontics are questionable to some extent. Why randomized clinical trials are questionable in my opinion? Because sometimes they're done by non-experts. Most of the randomized clinical trials are done in schools, academic institutes, and they write in their publication that the study was supervised by an expert in the field, but they don't mention that were done by students. And sometimes see large number of patients, they don't mention anything about the contribution of students to this. Students are non-expert, and sometimes we do compare. For example, if you compare headgear and functional appliance, we know that all of us have preferences. Some of us like functional, but they don't like headgear. That's why when you randomize, if you want to participate in this study, you have to do the two, either functional or headgear, although you are biased to one of them, an expert in one of them, but not expert in the other. And there is no blinding here because you can tell that this is headgear and this is functional appliance. Unfortunately, many of those studies use two-dimensional radiographs, which are expected to have errors in measurements. And now with CBCT, maybe it's a chance for us to do new randomized clinical trials to evaluate the outcome of our work. Inclusion criteria, as I said, they are broad. Sample size, in my opinion, is not adequate in most of the studies. It's not, there's no difference between 15 and 25. Still, the numbers are small. If you look at those randomized clinical trials conducted in medicine, you're talking about hundreds, thousands of people involved in those studies, but not with the range that we claim that's adequate, 25. Unfortunately, there are some studies that were sponsored and biased, sponsored by companies, and some were published in non-specialized journals, so the review process wasn't really good. And this is based on my opinion when I reviewed, because I teach in a school, I do a lot of literature review sessions with students, and these are my observation about what our literature. This example for the studies, like the outcome of randomized clinical trial done in North Carolina, evaluating early versus late treatment of class 2, and they came up with with certain conclusions that that really reduce the use of growth modification in the early treatment. And most of the people now, they believe in the evidence that we get out of this study, but I have many comments on it, but I think there's no time because 1:30 now, so I go flip over it quickly. If you have questions, you can contact me later. I will tell you why. But this is in general, the broad, the selection criteria were broad, when it was done also in academic institute, although they said phase 1 treatment was done under the care of a single faculty orthodontist according to a standard protocol. No details were mentioned about the headgear use or functional appliance, how did they use them. Sample size wasn't adequate. Treatment time was acceptable, although they claim that there is significant difference in treatment time between the groups of the headgear, functional appliance, and the control. But in my opinion, difference of 3-4 months is not a big deal because clinically, this time is what we do in the clinic. We see this variability in the clinic. And they said they concluded that the use or the early treatment using functional appliance or headgear did not reduce the chance or the need for extraction. Yes, because your inclusion criteria were broad. You didn't talk about or you didn't exclude those class 2 with flared lower incisor. If we have flared lower incisor and you do functional appliance treatment, then you need extraction later on because you'll flare them more. And as you know, in orthodontics, we don't just use any appliance. We tailor or individualize our mechanics to our patients. Maybe in one patient I use functional appliance, maybe in the other I use headgear. Comparing headgear to functional appliance is like you are comparing apples and oranges. It's not correct that both they do growth modification, but they have different mechanism of action. In addition, very important point, when in their most of the studies that were done to evaluate class 2, they mentioned that they had patients 1 year before growth spurt. Studies that were done early about growth and development by Bjork and Bishara, they said that the growth spurt is not, they didn't find growth spurt in most of their cases. Only in 40% of the cases had growth spurt. So it's not scientifically justifiable that we wait or take the patient at this age. So postponing treatment of cases with skeletal discrepancy in anticipation of growth spurt is not scientifically justifiable, and this is the conclusion done by Bishara et al. So what's evidence-based? As I said, evidence-based, in my opinion, has problem in our field, in orthodontics. We cannot apply it as is, but we should apply what we call evidence-informed practice. We have to use evidence from research, but in addition, we have to depend on the clinician experience and the patient's input. We have to see how these appliances are perceived by the patient. And this definition was taken from the American Dental Association, and it was titled Evidence-Based Dentistry. It's supposed to be evidence-informed practice. So for us not to confuse our community with evidence-based practice, because when you say evidence-based practice, it means that you have to have evidence from research. But when you say evidence-informed practice, that you have to use research in addition to other factors, which are the clinician experience and the patient's income, the input. So we have to have practitioner wisdom in the middle. So if you want to try something, you have to be good at it. You have to build your learning curve in order to be expert in the field. And you have to have the input of the family and the patient. See how they perceive this treatment. Is it acceptable by them or not? And later on, if it's something new, we have to build our evidence, whether it works or not. So now I'm going to talk about protocol that I advise you guys to follow if you have a new appliance. We shouldn't talk about evidence-based versus non-evidence-based. We have other steps that we have to evaluate before reaching this step. So this is my protocol that I want to share with you, or the guidelines for using or adding any new appliance or technique to your practice. First, try to add an appliance that solves a problem in your current practice. Some of us may be suffering from anchorage. So I say, okay, I'm going to add mini screws because this is going to solve a problem for me. But this mini screw has to be, I have to get something FDA approved. So it's causing no harm to the patients, biocompatible, non-toxic appliance. It has to be comfortable to the patients. I cannot bring any appliance and put it in the patient's mouth, which is not comfortable to the patient. It has to be biomechanically sound. So we have to learn some analysis. We have to know how to analyze forces, okay, in order for us to see the force delivered by this appliance. Is it okay or not? Is it causing side effects, problems or not? It has to give me stable results at the end. And then we have, or if you are a junior, go and find somebody who's expert in it. It has to be experience-based, somebody who have used it before and tell you, yeah, this is good. And the price has to be reasonable, so you don't have to change or compromise your prices in your clinic. And finally, when we have all these done, and after years and years, maybe you should look for the evidence, because building evidence in orthodontics takes years and years. This is the learning curve. So if you have a new appliance, you have to build your learning curve, not just try it once or twice, say, oh, it does not work, and leave it aside. No. Look how this curve, nice curve that I got from this website. So if when you start anything new, you are clueless. You don't know what you don't know at the beginning. Then after you attend a course or two, you naively you think that you are confident and you think you know, but still don't know what you don't know. And after a few cases, oh, it's discouragingly realistic. You start to be that. You know what you don't know. Now you say, okay, it's not working, and then you just quit. You're not supposed to quit here. You should continue until you master it and achieve the experience that you need in order for you to know. So you have to build your curve carefully, attending continuing education courses, workshops, try to add it to your clinic with caution, because you don't want to jump into 100 cases and you don't know how it works. You have to build your curve slowly. Let's look at the new appliances that we have in the market. For example, the self-ligating brackets, Damon brackets versus traditional brackets. Of course, looking at the Damon with the simple feature that has a self-ligating, no need to use ties, no need to use O-rings, and it's claimed to apply less force, and it's less friction appliance. All the first features that I mentioned, they are good for the patient, but what matters to me is less friction, minimum friction appliance. This solves a problem that we were taught and we are convinced that was a big problem in orthodontic field, which is friction. So why not we try it? This is a breakthrough in orthodontic field, that we have self-ligating brackets. Does it solve a problem? Yes, it does. Let's analyze it, see if you want to add it to your practice or not. It has minimum friction, so it means I solved the problem of friction. It also comes with different prescription. So those people who don't like rote prescription and see some side effects, especially in the canine region, and during retraction, maybe they can shift to this and choose their prescription. They use copper nitai wire, which ensures, according to, if you study the copper nitai wire's features, it ensures that you can apply more continuous and light force. And this is one of the objectives of our treatment, is to apply light continuous force. And it has well-developed wires. That's why the people that, the fan of Damon, they claim that with this appliance, you can expand arches. Unfortunately, this is, in my book, is a problem because it's against stability. So you have to be careful not to ignore all the three important features and focus on this one. No, even in the wires, you can change wires into narrower wires if you want to avoid losing stability, especially in the lower canine region. Is it evidence-based? Yeah, there are many studies done, and these are two recent review. One of them systematic review, and this is the other one, which is meta-analysis review. And it's interesting that upon reviewing the 11 articles in this meta-analysis, they concluded that further high-level studies involving randomized controlled clinical trials are warranted to confirm these results. So they found that self-ligating brackets are not superior to conventional brackets in many ways. But to me, who cares? If this cause no harm to the patient, if they approve and solve a problem to me in my practice, so why don't I use it? And it's biocompatible, and this is fixed appliance. Let's see these features here. Is it biomechanically sound? Yes, it is, with some limitations in rotation control, but the companies are working on it. But you can overcome that with several other methods. And if you not to expand that much, you can have stable outcome. And I think it's fantastic appliance since it solves a problem for you in your practice. This is one of the cases that was treated by a student in a postgraduate program. And you can see that, this is an institute where the treatment is free of charge. You can see how applying, this is also the Damon is relatively expensive compared to conventional brackets. And this guy, he just did the treatment, the bonding as is, and he ended up with many mistakes in bonding. And because it's expensive, and he was hesitant to rebond brackets. He kept the bracket as is until later on, and doing such appliance on the hands of non-experts, you cannot expect to have the same results when you doing it on the hands of or by the hands of experts. That's why those studies, the randomized clinical trials that are done in schools, are questionable in my book, because if they are done by students and many students, not one student, then you might have high variability, and this is a factor that we never consider in our clinical trials. Oh, we finished the treatment, as I told you, because we are really good in finishing the cases, and the patient has some reshaping and composite direct veneers. So we finished the case in a nice way, but we're talking about the details, whether this is superior or not to fixed appliance. This is one of the reasons that those trials sometimes are done by non-experts or biased people. This is another appliance, which is customized bracket system. I added this idea because really I'm not happy with the idea that we use one appliance that fits all, ready-made appliance with one prescription. Having this idea in mind, this is a brilliant idea to me, that we wanted to tailor our appliance to each patient. So when you take impression or scan and then you send it to the company, they also have another advantage that they can do 3D simulation for the appliance. So you show the treatment plan to the patient, and then you can bond it indirectly to avoid any mistakes. However, this is relatively also expensive relative to the Damon, the regular brackets, or to the conventional brackets. This example for the company that produce these appliances, Insignia. So, does it solve a problem? Yes, it does. It's customized to each patient. It solved the problem of a variation in anatomy that we see in different patients. Indirect bonding, yeah, reduce errors in bonding, but here you have to be careful. Why? Because when you do indirect bonding, you have to pay attention to the occlusion. If you're not expert in this, you might, like in the second visit, when you do bonding upper or lower, in the second visit, patient will come back to you with broken brackets because you didn't pay attention to the bite. Maybe you should open the bite in most of these cases. They give you 3D simulation. This give you patient's input, so you know how patients think, and they have to be satisfied about treatment plans. Wires that are used here with preferred arch forms. You can use your arch form that you want, and it gives you step-by-step treatment plan. So it's a very good educational way to add to postgraduate programs, and I think it's very useful to do that. Is it evidence-based? Yeah, there are studies that were done. Again, we have here an article that is published in a prestigious non-orthodontic journal, Journal of Dental Research, and they showed what they did. They did a randomized clinical trial. They compared self-ligating brackets Insignia versus conventional self-ligating brackets Dame. So they found that there is no difference between the two groups. The other day I wrote something in Twitter. I said self-ligating or Insignia or customized brackets are a very brilliant idea, and it's worth it that you try it. And one of the students or graduates from somewhere in Europe sent me this article, said, "Doctor, this is not correct, not true, because there is no difference between Damon versus customized Damon brackets." So if you look at this paper, although it's in a prestigious journal, Journal of Dental Research, there are some hints here that make these conclusions questionable. For example, these were done on simple to moderate cases. The PAR score index 123.3 to around the same figure in the other groups. So correcting simple cases is not difficult thing. We can fix it with fixed appliance, and we expect to finish it in no time. This is one. Second thing, Yeah, here they said one of the complications that was observed that the group, the customized group, had more loose brackets. Of course, loose brackets because this was done again by non-expert in indirect bonding. Maybe he is expert in diamond brackets, but non-expert, not expert in indirect bonding. And this is the problem with the results. Again, it should have been done on the hands, by the hands of experts, not anyone practicing just diamond. Is it FDA approved? Yes, it's similar to our regular brackets. This is the only difference that it solves the problem of having customized brackets for every single patient. If we look at all what we do, it's almost similar. We do things sometimes that are evidence-based, but they're really they're causing a lot of problems, and we still love them, like the class 2 elastics. And sometimes there's some companies that promote for their appliances in an incorrect way and in using strong conclusions. I'm going to show you here some of these. Like when you talk about class 2 elastic, this is bread and butter of orthodontics. Everybody's using it. Although when you do, of course, in the previous appliances, we didn't want to do a biomechanical analysis because, of course, we know these are similar examples to our fixed appliance. But here, if we do analysis for the forces applied by class 2 elastic, you can see the amount of extrusion that we do on the canine and premolars and the molars, and changing the occlusal plane, which is a problem sometimes in long faces. You don't want to make faces gummier. That's why this appliance was introduced, the forces fatigue appliance, which I like really because it solved this problem. It solved the problem of extrusion and changing the occlusal plane to some extent. Obviously, here you can see that's not hooked to the canine or the lower molar, upper canine, lower molar, so it has less effect on the vertical than the class 2 elastics. And if you analyze it biomechanically, you can tell that easily without any evidence. But from my experience, it's a little bit bulky here and not accepted by all patients, and this is the problem. But it still does wonderful job in my clinic, and still I use it because here in Saudi Arabia we have many patients with vertical long faces or gummy smiles, so you have to be careful in those patients not to use a lot of lengthy class 2 elastics. This is another appliance, the Career Motion 3D appliance, which is introduced using strong conclusion, like it's used to limit extraction and to turn difficult class 2 patients simple class 1 patient. These are strong conclusions that are not evidence-based. Although it's a nice appliance, and the author showed very nice results in his few case reports that he published and in all his presentation, but I have some comments against it. And of course, it's FDA approved. It's simple, cause no harm to the patient. But if you analyze it biomechanically, you can see that, of course, what's the carrier for those who don't know about the appliance? It's just this bar that is bonded to canine and molars, okay? And then using class 2 elastic, you take anchorage from the lower arch, which is supported by Essex retainer, in order to distalize either upper buccal segment or lower buccal segment. And it's segmented, like only canine to molars, canine to molar here. So if you do this, apply it, you know how class 2 elastic effect on the upper arch. It's extrude canine, extrude lower molar, which is be minimized by the Essex, but still it's going to extrude because the elastics used here are heavy elastics. And if you look at the occlusal also, these elastics sometimes, because we're trying to distalize, the molar will go lingual and the canine will go out. So you're going to change the arch form. I don't think this is like an outcome or something that is good to the patient. So here we created complication because we want to distalize. But basically, what you are doing, you are rotating the buccal segments. the canine out, the molar end, canine out, the molar end, and creating space mesial to the canine, and you assume that you distalize. But eventually, after you distalize and you do that, this is a case that was treated by carrier system, simple class 2 case. But I want to show you here something. After you create the space, then you have to go back to fixed appliance and use fixed appliance. So why not we start, instead of using this additional cost to the clinic, why don't we just do upper and lower fixed appliance with class 2 elastic? Because we know the elastics needs a lot of anchorage in the upper. If we use rigid wire, you can overcome any abnormal changes in the canine and molar. We can add second molars too and use elastic without the need for this carrier system. See the results? Nice results. We could have done that with just upper and lower fixed appliance and elastics. And still this was a lengthy treatment. You can tell that from the overall generalized gingival inflammation you see in this clinic, in this patient. The X-ray before and after. Again, one of the problems that is experienced by this appliance is the flaring of incisors, which occurs with class 2 elastic. So it's similar to class 2 elastic, except that it's segmented, only applied on the buccal segments, which is very dangerous. As you know, in segmented arch mechanic technique before, which was used by biomechanics people, they were recommending that we use transpalatal bar or lingual arch in order to stabilize buccal segments and to hold them together. This is another case, interesting case that was also treated by undergraduate students. You can see that this class 3 patients, we don't know whether this is pseudo class 3 or true class 3, but look at the canine relationship, a big distance between the two. So it's very difficult to treat without extraction. This is our concept, but with carrier you can fix it. See, they did Essex in the upper, carrier in the lower, and class 3 elastics. Look what happened. The case was changed from super class 3 into class 2. It's amazing. Do you believe that? I don't believe it. So what happened here? That yes, we rotated. So if you, this is the rule by the way, if you, any appliance that rotate the occlusal plane clockwise, like class 2 elastics, downward, then you can fix class 2 into class 1. If you move counterclockwise, upward, and rotate the occlusal plane, you're going to change class 3 into class 1. And this was changed into class 2. And look at the incisor. The incisor were out, totally out, and now with the appliance that is affecting only canine to molar without touching the incisor also moved backward into class 1 relationship. And you have a space here. This means that either we flared upper incisor because we use heavy elastics, or this is a case of, in addition to flaring upper incisor, this is a pseudo class 3 case that was not diagnosed as pseudo, was diagnosed as true class 3. So okay, we achieved class 2 canine and molar. Now we have to use fixed appliance to fix this. We extruded the canine. Is it acceptable to extrude canines? I think not, because at the end we have to correct the occlusal plane again by fixed appliance. We have to resolve the crowding that is created here. So again, with this appliance, we are creating some side effects that we later on fix. And we claim that this fixed all of our problems. Just by looking at this appliance and analyzing it from biomechanical point of view, I'm not willing to add this appliance to my practice, with all due respect. This is a study that was done and supporting what I said, and it's like 2000. I don't see the date, but it's a recent study, and they're saying the same thing, that with this appliance, the treatment time was almost similar, and was almost similar or even more. So the carrier appliance appears to be more effective or efficient than alternative in the treatment of class 2 malocclusion. So I don't understand, but I don't see it really, because this is in my way. I can't see the conclusion. But anyway, having randomized clinical trials will support what we do. But first, before we jump into the evidence that we want to look for the individual evidence. Look at the criteria that I mentioned before. Biomechanically, is it sound? Is it approved by FDA, causing no harm, causing no side effects? Then decide whether you add it or not. The last appliance, I just want to flip over it quickly. I know I'm almost done with the time, but we started like 5 minutes late, so I'm going to take 5 to 10 minutes. The clear aligner. Of course, nowadays we can tell that many companies now are working hard to introduce their new clear aligners to the market, and this is really good that we. To me, it's very fantastic appliance, and it has a room in my practice because it solves many problems to me and many others. Let's see how it's different from fixed appliance. It's almost similar to fixed appliance that treat malocclusion. It's invisible, removable, invisible, which is a big advantage to the patients, accepted by many patients, not all patients, many patients. Healthier because we don't see that much of gingival inflammation, and we use less force, assumed to be less force because of the increments of activation is less, so assume to have less maybe root resorption. And I have cases that had root resorption before, and then when I use this use clear aligner, I didn't notice any root resorption during that period of time. So maybe this is an appliance that is really interesting to everybody, one of us. But if we look at the orthodontist opinion in general, they know that this is their opinion, that effective for mild to moderate crowding, effective for mild to moderate spacing, not indicated for extrusion or intrusion. This is not correct. Indicated for relapse cases, yes, I agree. Not indicated for children, to some extent, yes, I agree, because although nowadays some companies introduce certain packages for children, not indicated when you have jaw discrepancies, yes, although some companies also introduce growth modification mechanism using the clear aligner, not as effective as fixed orthodontic appliance. Here I just want to highlight something. To me, clear aligner is similar to fixed orthodontic appliance, because even with fixed orthodontic appliance, we cannot do all the movement. We need to augment it with other things like expanders. We use RPE sometimes because fixed appliance alone cannot fix transfers. We use class 2 elastics, class 3 elastics. We use many screws. So maybe if you want to fine tune your practice using clear aligner, you have to add these accessories in order to make this appliance compatible to fixed orthodontic appliance. Biomechanically sound, yes, it does the same thing. It can apply the couple system on teeth, and it's controllable. It's very controllable when you do it with an appliance that's covering all the teeth, because here you don't have only 2-point contact, you have all over contact. You cover the whole surface, the whole crown with the appliance. Although the appliance itself not strong enough to do the desirable tooth movement, but the companies nowadays are working on that to improve the fatigue that is experienced after few days from wearing the appliance. I'm going to show you some cases. This is an open bite case in 65 years old, patient who's not willing to do fixed appliance, and he wanted clear aligner. And with cooperation, he had, of course, generalized recession and bone loss, and bingo, in 37 cases. Look at his x-rays. In 37 stages, we fixed his appliance. This is the treatment plan. See, we fix his teeth. This is the open bite, and this is after. This is the clean check. And the good thing about these appliances, the clear aligner, that I give you 3D stimulation, so you'll have patient's input to his treatment plan. This is after the first stage, and we did refinement. This is after refinement. Patient was very happy. very cooperative patients. We did some grafting on the anterior teeth because of the bone. He had some thin gingiva here, but this is the results. He's very happy. This is a clinician, wasn't happy about his crossbite anteriorly, so I gave him clear aligners, and this is the results after treatment. He was really happy with the results, and this is a case that after the first set of aligners, she had wonderful results in 4 months only. Of course, here we did intrusion for the incisors. Sorry, not this picture, there's a mistake. You can see here that we use class 2 elastic with intrusion mechanics, and we were able to fix the class 2 and the deep bite at the same time. And this is the patient after treatment. We allowed this canine to settle down with the fixed retainer, and then we added the clear, like the Essex retainer at the end. This is an open bite case. Patient wasn't very happy about his open bite. She didn't want to have fixed appliance. This is her results after the treatment. This is a case with a big diastema and arch. Look at the arch form. We changed the arch form, a nice arch form with clear aligner. So we're doing the same thing with clear aligner. But as I told you, if you think that has complication, consider it as fixed appliance, which has also the same complication, and we have to augment it and help it by additional mechanics like class 2, mini screw, and others. This is a case, interdisciplinary case. Patient had missing lateral. We had to move central, and create space for the lateral. And this is the patient after treatment, before and after. So he's very happy with the results. And this is again a multi-case, interdisciplinary case. Patient wanted to correct the canine forward and create space for implants. So we started with clear aligners, and we ended up with some fixed appliance at the end to finish residual spacing. But this is the results. Yeah, we helped it before. We added this power chain as a couple to derotate the canine, and then we started the clear aligner. And this is the patient after treatment. So we finished this case with some like maybe a few months of fixed appliance, and the patient was ready for implants. So now she was doing the implant. Unfortunately, as I told you, according to research, those appliances, they undergo fatigue after a week or so. They undergo intraoral aging because of the mechanical and chemical alteration that they undergo during treatment. And this is the weak point in this appliance. If it's solved, then I think this will be very good alternative to fixed appliance. Unfortunately, it has some drawbacks. Again, you don't have to be 100% sure of the results. You tell your patient that most of the cases you need to have refinement at the end or short period of fixed appliance. Price is a problem. Imagine that you apply around $2,000 plus or minus $2,000. In Saudi Riyal, it's around from 6,000 to 9,000 Riyal, which is a lot of money. So if you work in a company or if you work in a clinic, your lab work is the cost of lab work is very high. If you do 10 cases in a month, you're going to pay $20,000 a month for the company, which is as if you work for the company. And you're just selling this, and with their advantage system, they ask you to work day and night to achieve certain targets, only not to increase the price for you. So this is really devastating and annoying to me. That's why if I hope with new companies nowadays we have reduction in price, and I hope new companies give better prices to orthodontists to do treatment. Treatment duration, don't tell patients that this is faster. Tell them it's the same, but you have many other advantages. Patient accepted, not accepted by all patients. There's some patients that not cooperative, they don't like it because they drink a lot of tea and coffee, they're smokers, so they don't like it. They're not cooperative in many ways, so those patients should not have clear aligner. IPR is one of the problems, when we have crowded teeth, when we fix them, we have to do IPR. Doing IPR is still questionable, although Sheridan did his study, he found that, or most of the studies say that there is no difference between stripped enamel surface versus normal, but unfortunately, if you don't finish it, do polishing, good polishing to the surface, which is interproximal, I don't think this is correct. Aside from these side effects, I think in the near future, we'll have this clear aligner as the standard of care appliance. This is my opinion about the appliance. So as conclusion, I think it's time for us to change our traditional way of doing orthodontics. Remember, we need new appliance with predictable outcome. Use a guideline that I mentioned before you think about the evidence. When authority come and tell you evidence, there is no evidence, tell him still we need time to build evidence. When they say there is no evidence, doesn't mean that it does not work. It means there's no evidence. Could be good, could be bad. So we still, because I'm an academician, I don't want you to throw this evidence-based concept in the garbage. No, we have to consider evidence, but instead of evidence-based, you have to consider it as evidence-informed concept, because we need the experience of people doing it, and we want to take the opinion of experts in it. We need to have feedback from patients. And at the end, I would like to thank you all for listening, and I hope that I deliver to you the message that I want to deliver. And now we can have a few questions.
Thank you so much, Prof. Ali, for today's session. It's really very informative, and all the doctors enjoyed it. We have many messages like thank you, great session, thank you for your time, and they're all saying hello also as well, the doctors.
Thank you very much. I'm honored to hear.
It's our pleasure, Doctor, to have you as always. I would like to ask all our doctors to send us if they have any questions, and we can forward these questions later to Prof. Ali to get back to you. And again, I would like to thank you on behalf of Aramco for all the efforts and for your time today and for the great session as well.
Thank you.
Thank you. Thank you so much. Thank you so much, Prof. Ali. Bye-bye.